Okay. Hello, everyone. Happy Monday. I hope everyone's having a nice Monday and had a good weekend. Really excited to be here today. My name is Mark. I'm one of the CP Solvers members and a hospitalist at Stanford. I get to discuss with my friend Noah, who is a new senior resident, PGY2, and he's discussing at work, which is one of the hardest things to do as a senior resident. So super impressive. Noah, how you doing?
I'm doing good, Mark. Yesterday, me and Marcella, we welcomed Kirtan here to St. Louis and to WashU. And I was just thinking earlier this morning how it's crazy, like the connections and the friends and the family that we've made through CP Solvers just in a couple of years. I met Mark in person too, not that long ago in San Francisco while I was visiting Robbie. So it's so good to have this community. I'm super excited to discuss this case today.
Yeah, super excited. And then how about we give a shout out to Yusuf, who's doing scribing, and Kritika, who's also doing teaching points. Would you guys like to just introduce yourself, say, tell us how you're doing?
Hi everyone, I'm Kritika. I'm from India, Bangalore, India, and very happy to be doing the teaching points today.
Awesome, thank you. And Noah, or sorry, Yusuf, are you in a good spot, or you can't speak today?
Yeah, hi everyone. I'm Yusuf. Happy to help. Happy to be here today.
Awesome. Okay, and I think we have our case presenter, Robbie. How you doing?
Hey, great. Happy Monday. Hope you're well. Sort of have a case I had to dig up from a few years ago, but happy to be here to fill a void that you had. So hope you have fun with this case.
Really excited. And sorry guys, if I look very sweaty, I just came from the gym. I'm also like a little tachypnic right now, but yeah, I promise I'm doing okay. I just like ran back from the gym. But yeah, I guess Robbie, you want to go on with the first aliquot, and then I think Noah will tackle it first.
Absolutely. So today's case is a 58-year-old male who presented with chest pain. Chest pain, I'll elaborate a little bit, is constant, located substernally. It's crushing, non-radiating, intensity 9 out of 10. And I will stop there.
Now I'm sweating a little bit with this one liner, and I think that's a one liner that we see it very frequent in the hospital, chest pain. Um, so there is the 4+2+2 approach that we use here in clinical problem solvers to kind of rule out or at least think about the most dangerous causes of chest pain. So four cardiac causes would be ACS, so myocardial infarction, pericardial tamponade, heart failure or Takotsubo cardiomyopathy. Fourth one is I'm blanking. And then two pulmonary, PE and pneumothorax, and then two esophageal, food impaction and esophageal spasms could cause chest pain. Mark, I'm sure he'll tell me what's the fourth one that I'm missing. In chest pain, one thing that I want to make sure that to tell you is that Rabbi has taught us multiple times that it is a symptom that's so severe that your threshold for investigation should be very low. That means that I don't really care, like if the chest pain is like crushing, I care a little bit, but I care less if the chest pain's crushing versus radiating versus not. I'm worried regardless of the characteristics. Um, and I want a chest X-ray, an EKG, and troponins at least for all patients who have chest pain, especially when it's like this intensity and it's like a short interval versus like more chronic and ongoing problem. That's kind of what's on my mind right now. Those are the things I'm looking for if I'm seeing this patient in the ED. What are you thinking, Mark?
Yeah, totally. I almost have nothing to add. I totally agree with the the qualitative factors of the chest pain almost do nothing for me, honestly. Like you said, the radiating factors, how they describe it, really just poor test characteristics, right? To increase your post-test probability for things like ACS and PE. The things that really matter most to me is the past medical history, right? If this patient has hypertension, hyperlipidemia, heavy tobacco use history, or risk factors for PE, right? That'll kind of make those things rise on the top of my differential. So for me, it's really risk factors for those no missed causes of chest pain. And then really things that I ask all patients for almost every chief concern, this is not even really specific for chest pain, is when did it start? Robbie already gave us that. It's acute. What were you doing when it started? That can be really helpful as well, right? So if this patient was on a walk or on a run and their chest pain started, that might help a little bit with an exertional component. And then also, has this ever happened before? Because sometimes patients could be like, I've had this exact same thing, happen year after year. I was diagnosed with esophageal spasms. I'm getting treatment for that. Oh, okay. This is just maybe a flare of esophageal spasms. Just because it's happened many times before doesn't mean and it has a diagnosis attached to it, doesn't mean it's the correct diagnosis, but it does help kind of contextualize. So yeah, I totally agree with your workup too. The only thing I'll add is that in some patients, a D-dimer can be helpful too, I will say, in acute chest pain, especially if you have a low to like maybe moderate pretest probability for a P. And I think a thing that we also don't talk about too is that it actually has pretty good test characteristics for an aortic dissection as well. A D-dimer, I might be getting the stats wrong, but I think it has maybe like above 90% sensitivity for an aortic dissection. So it can help with those two risk factors as well, or an aortic dissection as well. But yeah, I would love to hear more of it.
Absolutely. Yeah, wonderful. I really love that not being stuck on the quantitative factors or the associated factors. So to add a bit more layer to the story, so when probed further, he's stating there's also shortness of breath, there's cough, there's yellow phlegm, and this happened 10 days ago. This happened around the time he was on a cruise. He came back and he tested positive for COVID at home. He did go to urgent care 3 days prior to this presentation because the symptoms were persistent. He was given doxycycline for possible superimposed bronchitis. Did not improve his situation. Prior to this, he also said that during this time, he's had dysphagia, difficulty eating, so he wasn't eating on the cruise as well. He had a weight loss of 10 to 12 pounds over the last 30 days. Negative factors, no PND, no orthopnea, no swelling of the lower extremities, no nausea, vomiting, no abdominal pain. He wasn't stationary on the cruise. He was pretty active, so he's up and about as well. And I'll stop there.
Maybe I can attack the kind of more subacute respiratory symptoms, and maybe I'll leave maybe esophageal symptoms to you, and we can like ping pong back and forth too. But yeah, it sounds like at least these respiratory symptoms are dating back about 10 days ago on a cruise, and this patient was diagnosed with COVID, right? Respiratory viruses are really common, right? Respiratory viruses are probably the most common cause of cough and sputum production, right? So that makes a lot of sense, right? But now we have like a preceding viral illness and now acute chest pain. I guess there's a couple ways that you can think about that, right? I'll just say, let's say this patient has COVID. There's always a chance that someone that has a viral infection can develop a superimposed bacterial pneumonia, right? And pneumonia in itself can lead to chest pain, especially more like pleuritic chest pain, especially when the pneumonia is more periphery located and causing like pleurisy, right? Pneumonias also can lead to parapneumonic effusions that can irritate the pleura and cause chest pain as well. So that's kind of a way that, again, like pneumonias can result in chest pain. Really, any preceding inflammatory state can increase your risk for MIs and PEs. I would say there's probably better literature for acute inflammatory states relating to acute coronary syndrome than pulmonary embolisms. I think more chronic inflammatory syndromes leading to PEs. But like classically, there's, I forget when the paper was, but in the New England Journal of Medicine, there's a pretty high link of influenza as a trigger for acute coronary syndrome. So you can extrapolate the same thing to coronavirus as well. And then you can just kind of think about also what are post-viral infection complications, right? There's some like local complications that you can think of. I should say this is more like someone has a pharyngitis, like a bacterial pharyngitis, when they can develop like, abscesses and Lemire syndrome, for instance. But like post-viral, you can think of pericarditis, myocarditis, right? Those both can cause chest pain in themselves. And even something like myocarditis, even though it's like an acute, cause of acute cardiomyopathy, essentially, you don't have to have signs of volume overload, right? You don't have to have lower extremity edema. You don't have to have orthopnea, PND. Myocarditis is an ACS mimic. It can have ST elevations. It can have a troponin elevation. It can look exactly like ACS, right? Same thing even with Takatsubos, right? Takatsubos can also be triggered by infections as well. So it's kind of something to think about. I think we'll make a lot of progress with the chest imaging here. Chest X-ray, or depending on what was obtained, maybe in the emergency room or by Ravi's team, a CT scan. But yeah, I'm very curious what the chest imaging shows. But no, what do you think about like the kind of esophageal symptoms patients have, or anything else you want to layer onto what I was talking about?
I agree with everything they were saying. I think that for me, a big thing that I'm trying to tease out in this case so far is, I know that there's this inflammatory subacute component to it. How much is inflammation still active, right? Like, is this patient fevering right now? Is he inflamed right now? And then he has like infectious complication of the infection versus, oh, he fevered in the past, this is now getting over, and now we're like in this post-inflammatory phase with the myocarditis, or maybe like a post-virulitis, which was very common in COVID. Not very common, but it was something that happened in COVID that can cause kind of like neck, chest pain, maybe some dysphagia. And then the dysphagia, I agree, it's kind of like out of the blue. I don't really see a way to connect it. The AMK was very helpful in the chat. When we think about connecting the dots, we can think about process A causing both B and C, right? So a underlying disease causing both the subacute inflammatory picture of chest pain and the dysphagia. Or we can think about process A was treated with B and then B caused C. So in this case, we treated the patient with doxy, and doxy can cause pill esophagitis, and then this is causing the dysphagia, which is what AMK is alluding to in the chat, which I think it's base rate wise would be most likely like a side effect of a medication that the patient was on. I think chest imaging and also like, is he inflamed right now? Those are the things I'm looking out for in the case.
Yeah, I love that. And I just want to clarify from Ravi, is the dysphagia has been going on for a month, right? And then the doxy was introduced like 10 days before the patient?
Correct. 3 days before.
Okay. 3 days
Doxy
before
was
the
3 days
patient.
before, yeah.
Gotcha. Okay, that's not. Yeah, and then no, I'll be very curious about. I found in real life, I've been fooled a few times, definitely by the classic teaching of how to differentiate like not as much like oropharyngeal versus esophageal, but more like a motility issue versus a structural issue for dysphagia. I do find that when you just ask patients to take a sip of water, I usually give patients a cup of water and see how they drink it. It's pretty easy to tell if it's really an oropharyngeal versus an esophageal dysphagia. But I felt that like when I asked patients, is it with solid, liquids, or both? Like sometimes patients say solids and liquids is a structural issue. Some people say just solids and a motility issue. So I'd be very curious also just to give this patient a cup of water also and just see how they're swallowing. And I think another thing that kind of could unify both too is something in the mediastinum, right? Something compressing the esophagus that's leading to thoracic issues, and then also dysphagia as well. But I'm definitely really concerned about the how rapid this dysphagia is too, right? It's been going on for a month and leading to significant weight loss. So yeah, I'm very interested where this case is going.
Okay, moving on to past medical history. Has a history of high blood pressure, hyperlipidemia, had hernia surgery about 5 years ago. Medications, I'll add it in the chat. So amlodipine, HCTZ, atorvastatin, and for family history, not relevant. Personal history, I'll add that in the chat too. He smokes 1 cigar per week for the last 5 years. Drinks 2 beers per day for the last 10 years, plus or minus 1. No illicit drug or substance use, no illicit substance use. Maintains a regular diet and also walks anywhere from 9 to 10,000 steps every 1 to 2 days. Very active. His exam, I'll just put that in the chat. So the exam is blood pressure 94/37, heart rate 203, respiratory rate 20, temperature 37.2, pulse ox 99% room air. Looking at him, he appears pretty ill. Cardiovascular exam is irregular, the pulse, and he's very tender on the chest if you palpate. No murmurs. Listening to his lung, there's decreased breath sounds, and he's breathing quite fast, 20 per minute. Rest of the exam is normal, no JVP, no peripheral edema. Abdomen is benign. And I'll stop there with this bit of data.
So very, very worried about this patient. Those vital signs. I think the map is like low 60s. I'm just glancing at it. Is the heart rate 203? Okay, well, for sure we need to act on that, and this is where management comes before diagnosis. So making sure that we call a acute care team, we have pads on, we find out exactly what rhythm this is, and we support him through that. I wonder if that's something that's part of the underlying process, or if the underlying illness caused him to like develop AFib or like to turn into AFib. Though 203, that's pretty fast for it to be AFib. So that's the first problem that I'm ignoring everything else, and I'm trying to fix right now. Looking back a little bit to the disease process itself. Yeah, I just wanted to comment on the timeline of the dysphagia, then shortness of breath, then chest pain. It seemed like it's a more subacute process, and I was confused with the timeline. And I think that the underlying problem would be in the esophagus or the mediastinum, and then we're seeing complications, downstream complications from that. But really, like, this is a moot point. If this patient dies right now, we need to act, and we need to act fast. So pads on, EKG, pending rhythm, we'll probably shock him, because I would consider that this is unstable. What do you think, Mark? How would you manage this tachycardia?
Yeah, I miss being on the rapid response team in residency. That was, I mean, obviously I never want any patient to be critically ill, but unfortunately patients get critically ill, and a lot of places I feel like in the US, the residents are on the rapid response team, and it's I think really, it's a fun team to be on. But yeah, I think the question, let's assume, like you said, is this, Robbie, did you say irregular rhythm, or I see regular?
Correct.
Correct. Okay. Gotcha. So, we're gonna, like you said, we're gonna get an EKG, we're gonna put the pads on. But yeah, if we're assuming that this is AFib, which would be the most common cause of an irregular rhythm, then the question is this, stable or unstable? And this patient is definitely unstable, right? I would be very curious of the patient's baseline blood pressure, but still, this patient has hypertension at baseline on 2 antihypertensive. This is probably way below the patient's baseline. So I would definitely want to assess for signs of hypoperfusion, which likely there is with that wide pulse pressure and blood pressure, but getting a sense of the patient's mental status, the extremity exam, their renal function, the lactate. But yeah, I would honestly shock this patient, given that this is likely an unstable atrial fibrillation, or cardio, cardioverth this patient. for the like next steps in management. I think the interesting question, Noah, is that what do you think about tachyarrhythmia leading to, well, so like hypotension or shock? Like, do you think, let's assume it's AFib is the driver of the hypotension here, or do you think it's like a consequence of the hypotension?
Yeah, this is such a big dilemma, and I think that there's a certain threshold where you can say, oh, maybe this is compensatory. I don't think 203 is benefiting him. I don't think there's like enough feeling for him to be, getting any benefit from this tachycardia. So I think, maybe there was a component in the beginning, but I think that has run away, and he would benefit from having a more regular rhythm with regular filling.
Yeah, totally. I think the classic teaching, and it makes sense physiologically, is that AFib is usually compensatory and it's usually not driving the shock unless a patient has a preload dependent state when they really need that atrial kick. So patients with severe aortic stenosis can go into shock quickly if they go into AFib because they're dependent on that atrial kick because that aortic valve is so stenotic. So I'm definitely going to be very or like say pulmonary hypertension, right? Patients with severe pulmonary hypertension cannot handle like atrial arrhythmias or arrhythmias really in general. They kind of just go into hemodynamic collapse. So I'd be very curious of the patient's TTE. I would definitely do a bedside POCUS here. I will say like I have like in situations like this, and not in this patient, but sometimes if you catch a patient, say you know what their TTE shows, say like you see they have like severe aortic stenosis or other preload dependent state, and they're like hypotensive, and on the monitor you're seeing their heart rate go up, see their AFib get worse, and their blood pressure go down. I have given metoprolol in situations like that because I'm seeing physiologically that their heart cannot handle going into AFib. And I remember one instance at the VA actually that I did that, and the patient got a lot better. I was very scared doing it. I remember the medical student looked at me. He's like, "Do you usually give AFib in those situations? The patient's a little hypotensive." Like, I was like, "Don't do that. Ask your senior before you do that, or you're attending." But I think those are rare situations. But yeah, no, I'm very curious about the EKG. Yeah.
Okay, I'm gonna share EKG with you just to sort of put you through the steps of the evolution of this case. You able to see that? Mark, you see it? Yep. Okay.
What do you think now?
It's definitely regular. I can't comment more than that. It's so hard to say when they're like so close together, and the baseline, it's like I can barely see the baseline. It's like what do you think? Do you see any?
Yeah, I mean, I agree. I mean, I think like first in these cases, I just kind of think about it as just like a narrow or wide complex tachycardia. And we definitely have a narrow complex tachycardia. And then like you're saying, irregular or regular, and this looks irregular. So we have, an irregular, narrow complex tachycardia, unstable, narrow, irregular complex tachycardia. So I think that kind of goes down the path of, we have to treat that with a, cardioversion. And I don't think we have to talk about kind of anticoagulation and stroke risk and all these type of things. It's kind of more nuanced and complicated, but I think, yeah, I agree with the initial management that you mentioned in the last aliquot.
Okay, so yeah, you're correct. This is a very rapid AFib, and in this case, what's interesting, the patient was, I'm looking at the case because it isn't mine. I would consider cardioverting. I've been in the situation, but this patient was given amiodarone, given metoprolol, given amiodarone, and actually became bradycardic. Normal sinus rhythm, rate 58, 60. And this solved this dilemma. But yep, in this case, this was what was done for this patient. But the other option would be blood pressure's on the borderline. The systolic was 94, and they were able to chemically cardiovert the patient. And I'll give you some labs. The chemistry pretty much was normal, but the lab results, the CBC showed a white count 23,000, hemoglobin 11, platelet count 382, neutrophil predominant 86.9, and troponin 1,000, initially 14, then 15, then 1570, and maxed out at 1760, and I'll stop there.
I forget whose turn it is, Noah.
You can go first. I'll take the opportunity to organize my thinking. So many things going on in this case.
Yeah. Yeah, no, I'm glad the patient is doing a little better. Yeah, again, I won't go into the complexities of like the amiodarone versus metoprolol versus cardioversion. It's kind of just in the moment decision sometimes. The only thing I'll say about amiodarone to keep in mind is that especially in intravenous amiodarone, the solvent that's in the amiodarone, it can lead you to be acutely hypotensive. So it's a little risky in someone also that has like a blood pressure of 94/37. It doesn't last very long, but it can. I've seen many patients get hypotensive right after getting a push of intravenous amiodarone. It doesn't happen with like oral amiodarone or anything like that, but I have seen that. So it's something to consider. But again, I'm glad the patient's doing better. But no, I'll say I'm not surprised by the labs at all. Like this is exactly what I expected the labs to be. Like this patient seems to have some sort of, subacute inflammatory state, leukocytosis, neutrophil predominant. A white count of 23 is pretty high for like, say, like we're operating under the hypothesis that there's some sort of pneumonia. I'm not going to say if it's viral, bacterial, fungal, whatever, there's some sort of infectious alveolar process going on, leading to the patient's symptoms. Like I'll say for like a bread and butter bacterial community-acquired pneumonia, it's pretty rare to get a white count of 23. So I'm definitely concerned that maybe this patient could have like an could have a lung abscess. It could have an empyema that's more, subacute and can lead you to have like a higher white blood cell count. So in this situation where this patient is so sick, was critically ill when they came in, I'm going to get like a CT scan of the neck and chest. I mentioned the neck because of the dysphagia. I just want to make sure I'm not, the chest is good for things in the mediastinum, but going a little higher just to make sure I don't miss any neck mass that's compressing on the esophagus or the trachea. But the patient is, just so sick. And, I think the chest x-ray is just like inadequate in this case, especially to pick up very, complications of pneumonia, look at the pleura better, and especially with the white count of 23. Yeah, I'm curious what you think about the troponin elevation and anything else.
So that's what I was asking Ravi in the chat. It seems like it was 14, 15, then 1570. So pretty big jump, and then 1700. So pretty dynamic troponin elevation. And this is a very high in his lab. It's a high sensitivity troponin. I do think, that it can be just from demand in terms of like demand mismatch going that fast. But I do want to see and scrutinize an EKG post-conversion just to make sure we're not missing anything else on top of that, especially with the clinical syndrome of chest pain initially. And this is a patient we're getting like a stat echo in assessing for any wall motion abnormalities could be useful to help, making a case for ACS, especially given like the whole confusion of the AFib. To be fair, AFib is not rarely the way ACS presents. And then looking more, yeah, I think I agree with you. I think there is an infection hiding somewhere in the white count. And I would look in the chest, look in the mediastinum, look in the neck. So I'm excited for some imaging. What would you do with the troponin? Do you think this is just from demand, just from the AFib, or are you worried at all?
Yeah, I have a love-hate relationship with high sensitivity troponins. I think in the general medicine wards, it's never ACS until it is. Like on the general medicine wards, I feel like almost every acutely ill patient that comes, older patient that gets admitted to the general medicine service has a troponin, that was obtained in the emergency room, and it's almost always elevated, and it's almost in every single one of my notes, and it's almost never ACS. So it's like another troponin that I have to, to trend to the peak and look at the EKGs. The one thing I always tell learners is that there's there's not a lot of urgency unless it's a STEMI, right? STEMIs need to go to cath lab right away, right? Non-ST segment elevation ACS might need to go to the cath lab quickly if they have usually an unstable ventricular arrhythmia, refractory chest pain, or they're just completely unstable. Now, the reason why I don't think like the patient's original presentation is like counts towards those like criteria is that it sounds like after the patient was treated for unstable AFib, now their hemodynamics are better and they're not like having a refractory ventricular arrhythmia. Because I agree with you, AFib is a very uncommon arrhythmia from ischemia. Ventricular arrhythmias are much more common. It can happen, but it's not common. So the patient doesn't really meet my criteria of I'm rushing someone, to the cath lab. I need a heparin, I guess heparin drip might be a separate conversation with the AFib, but yeah, I think there's usually no rush, and you can just kind of trend the troponins to peak. You can trend the EKGs. You can trend the patient's symptoms. And most of these situations, like I'd be so surprised if this patient didn't have a troponin elevation with how fast their heart was going and how low their blood pressure was. I would call the lab and say, "Are you sure the troponin's not elevated? Like, was that a mistake? Was that another patient?" So, and I think, and Andrew has taught me this too, like the degree of troponin elevation doesn't have the best performance characteristics for like ACS versus not ACS. The one thing I think we probably don't do the best job in hospital medicine is that if a patient does have a troponin elevation made to this degree, this high, I think it's something like after the dust settles, maybe this patient is diagnosed with something else, to at least put on the discharge summary and say, PCP, maybe consider an ischemic evaluation as an outpatient and make sure we modify those risk factors. Because, these patients probably do have some underlying CAD to mount that degree of troponin. But again, like I said, it doesn't always correlate that well. But yeah, that's my love-hate relationship with high sensitivity troponins.
All right, I actually have another follow-up EKG. So there was I had to move it from the original document. So patient had another EKG during this time as the troponins rose. And let me know if you can see it.
Maybe like diffuse ST elevation, except in AVR, which is depressed. You see that too, Mark? Or am I hallucinating? Both are possible.
Yeah, no, I definitely see it. I would have to zoom in hold on a second, let me zoom in. Definitely in like V2, it's tough for me a little bit to see the TP segment in V2 and V3, but definitely, yeah, in V2, V3, a little bit in V6. Some of it almost looks like J point elevation and maybe like V4 or V5, but yeah, I definitely see that ST depression in AVR as well. And the inferior lead, or at least in 2 as well. So we definitely have some V2 and V3, there's a different criteria, it has to be a little higher. I would have to measure that and look up the criteria. I can never remember the criteria because it's based on like age and gender. So I always look it up to see if it meets, ST elevation criteria. But we do see some, diffuse, probably diffuse changes. How does that influence your differential? No, like.
Yeah, so just going back to what we were saying at the very beginning about the flow of chest pain, pericarditis. So I agree. We need some more imaging, both of the chest and the heart, and echo, make sure that there's no effusion, and go from there. What do you think?
Totally, totally. I definitely would be trending these EKGs and interested in the patient's symptoms. And this patient certainly needs a
Yeah.
stat echo. One for, like you mentioned, the wall motion abnormalities. And I really want to make sure this patient doesn't have a huge pericardial effusion that's also leading them to obstructive shock. Because that would obviously need emergent pericardiocentesis. And like we mentioned, this patient had COVID, right? Had a viral infection, and we know viral induced pericarditis is very common. So I would put a probe, call the echo tech or whoever cardiologist, whoever does it at your hospital, and or just do one myself quickly. Yeah.
Okay.
And I missed, was it Robbie? Was it from 15 to 15,000? I thought it was all in the thousands.
No,
Was it?
no, 14, 15, then 1,000, 1,700. So it rose.
Okay.
And so an EKG, there were a couple EKGs, but I went for the one that showed the changes. So you're both correct. There's a concern. There's diffuse ST elevations. Let's move to imaging since I have the screen. Are you able to see this image?
Yes.
Oh yeah, there we go.
So I don't see, I'm just gonna speak out loud. Like, I don't see any effusions. That's what we're looking for, like pleural effusions in VMR. I don't see any. The angles are very nice. I don't see any obvious consolidations in the lung parenchyma. The mediastinum is kind of nice and narrow. And then I do see that the heart's pretty big. So pretty big cardiomegaly. Those are the things that kind of stand out to me.
Yeah, totally. I totally agree. And then also, we were also looking for some consolidations too, and yeah, I agree. I don't see anything. I mean, maybe that right mediastinal border or right heart border is like a little obscured, I guess. Like but and no, anytime I think of cardiomegaly, so and you'll hear. I feel like this is just like something that like attendings like to quote unquote pimp on. I think there's honestly no utility of it. It's like a useless question, like almost like a useless thing to ask. But like you'll hear people say like you can't call cardiomegaly on an AP film, but like it's if you're worried about cardiomegaly, you're just going to get an echo anyway. So I think it's like a moot point. But anytime I think of cardiomegaly, I also think of like, could this heart be enlarged because there's fluid around the heart too? So could this not be cardiomegaly and actually just be a pericardial effusion that's making the heart look big? So another reason that we need an echo as well. Yeah, and then I agree. The mediastinum doesn't look too big, and that like esophagus doesn't look compressed. Sometimes it's tough to see the trachea, the trachea doesn't really look compressed or deviated at all. But yeah, tube of truth, as David is saying, and an echo, I feel like can be really helpful.
Awesome. I think showing you the images and EKGs actually helps a lot in trying to understand what's going on. So the read on this film, you're absolutely right, Mark. There's generally nothing remarkable, but this hilar region was very suspicious, and either this was an AP view, do a PA and lateral, or do a CT in this case. A question like troponin and this EKG, what do you want? What would you do next? And say ongoing chest pain.
Yeah, that's a tough question. Ongoing chest pain, troponins, and these EKG. I'd favor I'd call cardiology for sure. Plus minus on the anticoagulation. I think that giving the patient the ACS treatment with Lipitor and aspirin is benign enough that it's warranted while cardiology comes by and assesses the patient. Doing nitro and assessing response if the patient's pain gets any better. I think uncontrolled chest pain and a troponin elevation, even though we're saying it's pericarditis, I think it's pericarditis. I think that we don't have strong enough evidence to say it's not ACS, if that makes any sense. What do you think, Mark?
Yeah, I always like to think of too, like what I would do in a situation also when there's no cardiology, because like many, just many places, there's not access to specialists. And I just like to practice that as well. And I think it wouldn't be unreasonable, like you said, to do complete ACS treatment, right? Even to start this patient on a heparin drip, right? This patient has new atrial fibrillation. There's changing, I feel like there's always changing guidance on whether like one isolated episode of AFib, in a critically ill patient, does that qualify them for, anticoagulation if they meet Chad's mask? And I won't go into that, but, they have an indication already probably for anticoagulation, and they don't have really obvious bleeding risk factors that I'm, thinking about the platelet count, and there's no signs and symptoms of bleeding. So I don't see any obvious bleeding risk factor. So yeah, I honestly probably would, especially if the patient's having, say I couldn't get a stat echo right away either, because maybe if they have a stat echo and they have, this huge pericardial effusion, then maybe I'll more so go down that route, that route and the pericarditis route. But I think if you couldn't get a stat echo right away, which a lot of places can't, I would probably do heparin, aspirin, atorvastatin, and to all the ACS things, and hopefully, consider a cardiac cath, for sure.
So
there's one other, yeah.
yeah, absolutely, yeah. So that was my question. So
can I say one?
Yeah, go ahead.
So the one thing, Noah, I think it's just to be careful about the nitro in this situation, just given the patient could have potentially a very preload dependent state if they have a large pericardial effusion. So that's the only thing I would be careful of is the nitro. Anything that drops really quickly could be dangerous in someone who has a large pericardial effusion. But yeah.
So great pearl. Yeah, definitely avoid the nitro in this case. So this patient was urgently taken a cardiac cath because of this ongoing chest pain, rising troponin, and the CKG, which was questionable. And they found a spontaneous coronary artery dissection involving apical left anterior descending with matching inferior apical wall motion abnormality. There's also EF of 55%. And I'll also tell you the TTE that was done right after. So mild concentric LVH, normal RV, small pericardial effusion anterior to the right ventricle, no tamponade. And that's the end of this aliquot.
I'm very glad that he was taken to cath. Yeah, I think some other places, some other people wouldn't have cath this patient. I'm glad they did because that's pretty bad. What do you think, Mark? Were you surprised? I'm also surprised. I was expecting a big effusion, no ACS.
Yeah, I guess. What do you think about the dissection? The SCAD. What are your thoughts on that?
In terms of what?
I guess do you think? Have you seen a case of SCAD before? No, gotcha. Yeah, and it's. I think in the beginning we talked about also kind of, I guess what kind of defines ACS, right? Most causes of ACS, right? I think about 70% of cases are from acute plaque rupture, right? You have a patient that has coronary artery disease. They have plaque rupture and thrombosis, right? That's most cases that we see. But then there's a bunch of rare causes of ACS, right? So I think it's always good to think about a differential diagnosis for ACS. And essentially, what are ACS mimics? Things that don't lead to coronary ischemia, but are ACS mimics because they lead to acute chest pain and ST segment elevations, like Takotsubo's, for instance, right? And myocarditis that can look exactly like ACS clinically. And then things that are not acute plaque rupture, but then lead to, coronary ischemia. So spontaneous coronary artery dissection is one of those, right? You can have a coronary artery thrombus, like embolus, it's very rare, but someone that has endocarditis and then has an emboli in their coronary arteries, or someone with APLS that has non-bacterial thrombotic endocarditis and then has a clot in their coronaries as well. You can get these calcium deposits in your coronaries as well. That's theorized as also a cause of ACS. Vasospasm is also kind of in the ACS bucket. So there's things that can happen to the coronaries that are not just acute plaque rupture. I've seen probably, I want to say like 4 or 5 cases of SCAD, all in the I think almost every case was actually what's it called? The word I'm looking for? After pregnancy, like around the time of pregnancy. So it can happen around that time, either like in the 3rd trimester or right after delivery. It can happen. It's also associated with like fibromuscular dysplasia and other kind of like connective tissue diseases like Ehlers-Danlos syndrome. I think there was original thought that there may be an association with like systemic autoimmune diseases like lupus and other things like that, but I think that has actually fallen out of favor. So I think, and the other thing is, I think there's also a theory that some causes of Takatsubos are also related to SCAD as well. I think there is an association between Takatsubos and SCAD. So I forget if there was some wall motion abnormalities that were consistent with Takatsubos. I think I didn't hear the full wall motion abnormalities, but yeah, SCAD's managed a little differently. I think all centers kind of manage it in a different way, whether some centers will like stent depending on like the anatomical characteristics. Some centers use different like ACS therapies. I think there's not like a consensus on it. So yeah, Robbie, what was the cath and echo wall motion abnormalities? Was it in the Takatsubos pattern?
Not in Takatsubos, but
Okay.
it was where the SCAD was, the inferior apical area was having diminished the wall motion abnormalities was diminished.
Gotcha. I will say in most cases, Noah, SCAD is actually typically an endpoint diagnosis. It's usually like it's associated with a younger female associated with pregnancy. I don't think not a lot of patients get a more extensive workup. I have seen patients that have gotten imaging of their carotids and their renal arteries to see if they have any evidence of fibromuscular dysplasia. Probably wouldn't be at play in a 58-year-old male, but honestly, a lot of times it is like an endpoint diagnosis, unless you have features concerning for like a connective tissue disease. And again, like not like lupus, but more like Ehlers-Danlos or Louis-Dietz and those kind of things.
Yeah. Do you think in this case it's the end of the story? I don't think I agree with the chat. I feel like the SCAD doesn't explain why this patient was having dysphagia for a month before, why he had this subacute presentation. And I'm still curious to see what the imaging of the chest will show. What do you think?
100%. I should say, when I say endpoint diagnosis, I just mean for the SCAD itself. Like this patient has something else going on in their esophagus for sure. That we definitely need some imaging of the neck and the chest. So yeah.
Yeah, and like this case is kind of interesting because what are the likelihoods of you having SCAD in someone that doesn't fit the demographics and also being like coincidental versus just being like linked to the underlying disease process? So I'll be, doing some lit review on SCAD and if there is any association with like infection, maybe COVID, or maybe the underlying disease process that this patient may or may not have.
Yeah. And I think I've seen cases too that I think sometimes like interventional cardiologists will disagree on whether they think something is SCAD or not too. So I think there's also some inter-operator variability too.
All right, let me give you more imaging. So we're down to the last aliquot. After this imaging, I will share what transpired. Are you able to see the CT?
Yes.
That doesn't look good. What do you see now?
I see something, but I actually don't know what it is. Where is that? Like, which structure is that?
So yeah, I'll kind of help you as time is running. So this is the esophagus, and so the esophagus has intraluminal abnormality and thickening. There's thickening around the esophagus. Lower cuts also showed a necrotizing pneumonia. And with this and his dysphagia, an esophagram was then also recommended or done. And the barium, so with this esophagram, if you can see it with barium, and you see here, you see an obstructive mass in the mid-esophagus, and there was also an esophageal pulmonary fistula. Eventually, with biopsy, a poorly differentiated squamous cell carcinoma with extensive necrosis was determined. And clinically, the patient was stage 4A, unresectable with local extension. And I'll stop there.
Wow. So sad for the patient because it doesn't seem like they have a good prognosis. Very interesting case. Shout out to David in the chat. He mentioned the possibility of the esophageal pulmonary fistula, explaining this dysphagia and then subacute inflammatory syndrome link, which makes sense in retrospect. The patient had a problem in the esophagus and then was having pulmonary manifestations. They're close together physically, but they're not connected. Now, if there's a connection and then a necrotizing pneumonia, that can explain all the underlying illness, and then maybe the illness triggered this cath, just the stress of it. Maybe the AFib, who knows? What do you think, Mark? What a wonderful case.
Yeah, no, it's sad case, and I think that series of events makes total sense. I think it shows too that like it's really hard sometimes to make. I think always got to take dysphagia, especially in someone that's greater than 50, seriously, and sometimes it's tough to make progress on the history until you have imaging, CT scans, barium swallows, and then you can kind of make more progress. But I think I'm trying to think like what have we not explained. I'm just going to kind of summarize what you said, right? This patient had dysphagia. We have an esophageal mass that has poorly differentiated esophageal squamous cell cancer. So we've explained the dysphagia, right? This patient had COVID and then has had like ongoing respiratory symptoms, and now we have a necrotizing pneumonia, right, with a fistula. So we have a reason why this patient would have a necrotizing pneumonia, and this patient would need broad spectrum antibiotics for this necrotizing pneumonia. And then we have SCAD, and I totally agree. Like I said, I think that at first when I saw the esophagus, before Ravi said the cancer, I was like, is this thickened? Is this maybe in the lower part of the esophagus? Does this patient have scleroderma? And then, is scleroderma associated with SCAD because scleroderma is an underlying vasculopathy, right? I think there might be cases of SCAD with scleroderma. I have to look that up. I feel like I remember reading that association before, and I think it makes sense given the underlying pathophysiology, but obviously we have a biopsy now that shows cancer. So yeah, I mean, I think catecholamine storm, and again, like I said, I think that you don't always have to go searching too much for an underlying cause of SCAD, to my knowledge. But I think we have a pretty good story, a sad story, but I think a pretty decent series of events. I feel like Ravi might have like one more thing, and I'm trying to guess exactly what that would be, but yeah, I don't think so. I can't think of anything else.
Absolutely superb discussion. I think there's so many layers. When I actually was presented this case, so it's one of our former residents, and it was just a maelstrom of data. So what can happen is with your cognitive load, you're thinking initially, and you were right on the money. I think if you go back and process this, the X-ray, that right hilar region was very suspicious, right? So you would have gone straight to that area, and it does kind of have a question mark, is it malignancy? But then you're confounded by this, the AFib RVR, the STEMI kind of picture, the cardiac cath, the troponin, and it's so easy that can deviate you away. And if you're not careful, you lose sight of what initially was troubling the patient. So multiple layers. I thought it was a good case to kind of go through. In real time, you presented the data in sequence and how some of these cases can really deviate you away from what the primary issue was. So splendid job, both of you.
What do you think, Noah?
Yeah, thank you for co-discussing with me. Thank you for keeping us on track. Thank you so much, Ravi, for putting together this case. It was like, oh, we were thinking about something, and we see the vitals, and then we jump to something else, and then we see the troponins, we jump to something else, and it is very easy to get distracted. But I'm glad that your team didn't get distracted, and I'm glad that your team was able to find the answers.
Ravi, how did the patient do in the end?
Yeah, unfortunately, was put through chemotherapy, didn't do too well, and had to be placed in hospice and palliative care. So unfortunately, passed away. But the family was happy, at least before this. The patient was able to go on a cruise and enjoy themselves. Didn't get very sick in the cruise. The COVID, unfortunately, cruise ships viruses spread, and that was what really brought him in. If he didn't get the COVID, he wouldn't know what was happening.
Yeah, I think I'm so sorry about the patient, but thanks for allowing us to learn from the patient. And yeah, no, it's so impressive. Like you're on call right now, and as a new senior resident, you're discussing a case like in the middle of the day. I would never be able to do that. So thanks for discussing.
My interns are amazing. They got this.
Kritika, we'll turn it to you for teaching points.
Yeah. So we had a patient here who was a 58-year-old male with chest pain. So Mark mentioned the +3+2 approach for chest pain. So cardiac causes could be acute coronary syndrome, any myocardial infarction, tamponade or cardiomyopathy, respiratory causes like pneumothorax and pulmonary embolism, and GI causes like esophageal spasm or rupture. And also the first line investigations that we would think of are ECG, troponin, and chest X-ray. And also, we would like to know more about the past history, the onset of the symptoms, and what the patient was doing at the time. And we also got additional symptoms like cough and sputum. So we were thinking more on lines of a respiratory cause. So something like pneumonia with pneumonic effusion, which could cause a pleuritic chest pain, and other infective causes like pharyngitis, pericarditis, myocarditis, and also Takotsubo could follow any infectious causes. And also sometimes doxycycline can cause esophagitis. And also the patient had dysphagia. So one point was we need to differentiate whether it is due to a motility problem or an obstructive cause. So if once we give a patient something to swallow, so we can make the difference based on whether it is only to solids or to solids and liquids. And here the patient had a very high heart rate of around 203. So we wanted to know if the hypotension was causing the tachycardia or if it was the AFib which was causing the hypotension. And CT scan of the neck and the chest shows dysphagia, and high total counts was considered. And we also wanted to get a 2D echo to rule out any region motion or abnormalities. And Mark mentioned that NSTEMI should be taken right away to cath if there is an unstable ventricular arrhythmia or if there is refractory chest pain. And in this patient, we had a suspicion of pericardial effusion. So nitrates or any drugs which will reduce the preload was suggested to be avoided. And we got a diagnosis of spontaneous coronary artery dissection, which is generally a endpoint diagnosis. And we can suspect it generally in young patients who are pregnant or in any patients with connective tissue disorders like Ehlers-Danlos or any autoimmune conditions. And it could also be associated with Takotsubo's. That's it.
Wow, those are so detailed. Thank you so much. I hope everyone has a great rest of your day. See you, friends.